Very good afternoon to you. Welcome to this program on Neuro Ophthalmic optic disc conditions. It's an instruction course. I request Dr. Vijay Raghavan, Dr. Saravanan, Dr. Karthik and Dr. Amruta to join us on stage. So we are going to discuss overview of some of the optic disc conditions which are not glaucomatous. So it's just an overview without wasting time. We'll have Dr. Saravanan deliver the first lecture on AION. Over to you, Dr. Saravanan.
Thank you, sir. Thank you so much. So this is one of the very common diseases which we see in patients above the age of 50 years, 45, 50 years. And typically, this disease mainly because of the decrease in blood supply to the optic nerve head, which can have commonly the most common presentation being the non-arthritic, and occasionally you have a case of arthritic type also. Compared to the Western population, our incidence of arthritic is quite less actually. So whenever you see a disc edema with a vision loss in a patient who is above 50 years and especially has systemic disease like the dyslipidemia, hypertension and ischemic heart disease, first you have to think about ischemic optic neuropathy. If it is in a young patient, you think of inflammation first. And the vision can vary anything between 6/9 to PL, but usually what we see in our clinic is around 560 or less, 360 to 560. That's the usual presentation which we see. And just showing a few case examples. This is actually a 60-year-old, 58-year-old male patient who came to us with a vision of 660, and the duration was more than 6 weeks. He came a little bit late. And by the time he came to us, you can see the disc edema is resolved, and you see a superior disc pallor, which is what we commonly see in a patient with the resolved anti-ischemic optic neuropathy. And the left, as you can see, has got a slightly smaller disc with no cup, which again indicates the disc at risk. So this is one of my own case where I missed the diagnosis. It was a young patient who had a mild dyslipidemia, and he came with the anti-ischemic optic neuropathy in the right eye first. And I knew that I was missing something here, and because the hypertension was very mild, the dyslipidemia was very mild, but as a young patient, we don't think about these things as a main cause. And I sent it to a physician, but he ruled out everything. Nothing is, he didn't pick up the main issue, that was the factor V Leiden deficiency. But he later developed ischemic neuropathy in the other eye after around 1.5 to 2 months, and then only I sent it to a different physician, and that's when we came to a diagnosis of factor V Leiden deficiency. And by the time we came to a diagnosis, already he had lost vision in both the eyes, and one eye was 560 and other was 660. Unfortunately, he could not continue this job, and he really suffered actually. So there are a few reports about the role of factor V in ischemic neuropathy in young patients. So one of the differentiating factors compared to other disc edemas is RAPD, which is always present, and disc edema which will persist around 1 to 1.5 months, and after that disc atrophy sets in, and if we do ultra HFA, you will be seeing usually inferior field defect. So pain is not always a usual finding like in optic neuritis. People still can have headache and pain, but it's not a very common like you would see in an optic neuritis patient. So one other case where we had a misdiagnosis was amiodarone. One of our clinic was amiodarone optic neuropathy, which is quite long-lasting, does not resolving for more than 3-4 months. And then we realized after doing some research that it was actually not ischemic neuropathy; it was actually amiodarone optic neuropathy. So if you have case of doubt, you do a fundus fluorescein angiogram and look at the early phase frames of the section, because once you see the later frames, it will start leaking profusely. So you can see here there's a case of a disc edema in the left eye, and you can see the superior half. You can see the early frames. There is a hypofluorescence, which indicates a decreased perfusion, and you can see the reactionary dilatation of the vessels in the inferior quadrant. So if you look at the HFA, you can see the altitudinal defect in the inferior quadrant. And this is after resolution, you can see the loss of ganglion cells and as well as the RNFL, leading to a superior sectoral optic atrophy. One more case of ischemic neuropathy in the right eye. Again, you can see the typical superior disc pallor, and the HFA shows the initial hypofilling defect in the upper part of the disc. So if you do OCT, SRF is not a usual finding, but occasionally you do get SRF. But if you get SRF, you have to think about neuroretinitis as a first. Especially the SRF is very profuse, you have to think about neuroretinitis is the first choice. But in case of AION, you do tend to get some amount of SRF in the posterior pole, not in every patient, but in some cases, especially in the papillomacular bundle area, you can see a little bit of thickening along with the cystoid changes and subfoveal minimal SRF. But it's not a common finding. Don't expect this to see in every single patient. So in a resolved case, one common question is because in post AION, the secondary optic atrophy, you have a sort of a shallow a large cup, and then the question of the pallor associated, there's a question of whether it's a open angle glaucoma or whether it's a sequelae of AION. So if you look at the field defects, usually in a glaucoma you get an inferior notching which leads to a superior defect, field defect, and AION it's reverse. So this is one of the differential findings, and the disc cupping is usually quite shallow in post AION optic atrophy compared to a deeper cup in the glaucoma patients. So OCT angiography can also be a little bit of a differentiating factor. If you do, you can see that the loss of the surface capillaries in the optic nerve head. So OCTA or OCT angiography can also help to clinch the diagnosis when there's a doubt of whether it's a post-AUN optic atrophy or is it a NTG or early onset glaucoma. So this is one more case of a 32-year-old female coming to us with a loss of vision of around 624, and you can see a disc edema, and when you do a fluorescein you can see the superior disc defect, but if you look at the posterior pole you can see a lot of leakage indicating a cystoid macular edema. So when you see cystoid macular edema and you see in the OCT angiography, you can see a secondary surface neosclerization. It's a mostly inflammatory disease rather than ischemic neuropathy. So sometimes FFA and OCTA can sometimes help you to differentiating inflammatory disc edema when you think about in a young patient, which is not a first choice actually. So patients, sometimes in young patients when you have DD, first thing you look at is whether it's optic disc drusen, and obviously when you do the edge, you can see the elevated and blurred edge of the disc, and once you do autofluorescence, you can see the typical hyperfluorescence indicating the presence of optic nerve head drusen. So one other DD, when you have, you can see the ultrasound also picks up the foreign body like hyperechogenic lesion in the optic disc, again indicating the presence of drusen. So when you see a patient with bilateral disc edema but no vision loss or only history of transient vision loss, especially in the early stage you don't get vision loss. So when you do a doubt is first disease is a papillary edema. To clear the doubt, you do ultrasound. You can see the presence of the typical fluid around the optic nerve. That's called a crescent sign. Again, if we do it in a different cut, you can get the donut sign all around the disc. So whether the presence of crescent sign or donut sign will help you differentiate the bilateral disc edema with no vision loss. You can easily rule out papillary edema. Even before you send the patient for neuroimaging, you can do a ultrasound in your own clinic and clinch the diagnosis of papillary edema. So when you have a confirmed diagnosis of AUN, how to go about evaluating this patient is first you have to rule out the cause-and risk factors, which is quite often there: hypertension, lipids, diabetes, ischemic heart disease, and one more usually missed causes the obstructive sleep apnea. So in case you can ask about snoring and whether they have day-night sleepy feeling. So this will clinch you the diagnosis of sleep apnea. You can also send to a sleep study to confirm the presence of sleep apnea. So these are some of the things which you look at. The other eye, if you look at, you will have a small disc with a small cup, so that indicates the disc at risk. And this case have been reported after Viagra. We have both CRAO and ischemic optic neuropathy post Viagra also. So these are things which you have to look at, and you have to advise the patient to discontinue other bad habits like smoking to help them to prevent recurrence from happening in the other eye. Other rare causes are polyarteritis nodosum, SLE, Berger's disease, vasculitis, and sometimes syphilis and TB can also cause inflammatory, which may mimic these situations. And the serology, which will include ESR and elevated CSR, you can do CRP to confirm also. And other rare causes of protein C and protein S, so that and antiphospholipid antibodies, all these things should be ruled out. So and mainly the other eye, you can just showing the difference between the normal disc and a small disc. There's a normal disc on the left side and the small disc with a crowded small disc with a disc at risk appearance on the right side, just to give a comparison how a disc at risk looks like. So mainly there is a hyperprovision of the immediate to the lamina corpus of the posterior arteries, and over the follow-up around 30% may recover a little bit of improvement in vision, and 20% can lose, and most of the patients vision remains unchanged from the presenting vision. So one of the main surgical interventions tried out was the decompression surgery, ONH decompression surgery. Unfortunately, the ONH TT trial, the ischemic optic neuropathy trial did not show any difference in medically managed as well as surgically managed patients. So currently, it's not the treatment of choice. And as you can see, the Harris article showed that there's a circle of Zinn. That's where all the ischemia is happening. And right now, we don't have any definite treatment for this disease. And mainly to protect the other eye, you take care of all the systemic diseases, and aspirin may help to prevent the risk of other eye developing ischemic neuropathy. So arthritic is much more severe grave disease, and unless you treat the patient immediately, the other eye is going to lose vision. It's mainly a vascular disease and more common in females and around 50 to 60 years. And you can see the extensive pallor in this patient of arthritic ischemic neuropathy. The significant disc pallor with a lot of edema. So in these patients, we can do a temporal biopsy to have a confirmatory diagnosis. And now we have the presence of newer MRI techniques which look at the temporal artery so that you can get a medical, without doing a biopsy, you can get a diagnosis of arthritic ischemic optic neuropathy. The presence of other malaise, fever, and jaw claudication, tenderness on pressing the scalp tenderness, especially during combing and all those things. This can also give you help to clinch the diagnosis of arthritic type of, and obviously the ESR is going to be super elevated along with the elevated C-reactive protein as well. So treatment for this in arthritic type is going to be admit the patient and immediately start the high dose intravenous methylprednisolone steroids, and the oral steroids can sometimes be continued over 6 months to 1 year, or sometimes even more than that, depending. Better to refer them to a neurologist or a neurosurgeon to take care of this long-term follow-up and treat them. In some cases, antimetabolites can also be tried, and thank you for the attention. I'll stop here and take questions if there are any.
Thank you, Dr. Saravanan. Actually, AO1 is a very important topic. Some of the conditions where we miss preoperatively, even for cataract, optic disc, and macula, then we end up having a suboptimal vision. Thank you for an overview of AON. Now I invite Professor V.R. Vijayaraghavan sir to talk about optic neuritis. Over to you, sir.
Good morning. My topic is on optic neuritis, the importance. I think some PGs are here. My usual question, optic nerve, is a nerve or not? Your answer should be, it's not a nerve. It's only a white fiber tract connecting second order neurons, that's ganglion cells, to third order neuron is actually iatrogeniculate body. It's going as white fibers, that's all. That's why, optic nerve, still we call it as optic nerve again, but normally it's not supposed to be a nerve. And moreover, it has got no neural lemma. That's why when you get injured, you cannot regenerate. That's the major problem with optic nerve. Whereas but seventh nerve is there, you can have apparent regenerations. Third nerve is there, apparent regeneration. So many things can take place. Whereas optic nerve, when get damaged, it can never regenerate. Now we have got sometimes optic neuritis is there, isolated. Always remember, whenever you encounter a patient of optic neuritis, think the patient in future may develop multiple sclerosis. That's the most important aspect you are supposed to know. Then based on pathology or something, we can differentiate or tell it as periaxial, axial neuritis, transverse neuritis. That's the importance, why I'm telling now. Everyone knows that optic neuritis can have a visual field defect of central scotoma, centrocecal scotoma. That's what we know. But most important point, and which axons are involved, you are supposed to know. In optic neuritis, suppose the peripheral axons are involved, you can have peripheral contraction also. Once one in the macula fibers is involved, you get a central scotoma, that's all. That's why always central scotoma need not be always this problem of optic neuritis. It can be anything. That's why we should not get confused. So just by seeing the field, we cannot tell it's optic neuritis. Optic neuritis patient can have even peripheral that is contraction also, the fields depends upon that. Now when you see the fundus examinations, papillitis, of course you can see that, neuroretinitis, and then retrobulbar neuritis. Retrobulbar neuritis, everyone knows, you cannot see anything. The patient sees nothing, doctor also sees nothing. That is what being described as retrobulbar neuritis. Major etiology is what? Optic neuritis, if I asked as a postgraduate, always never forget tell about demyelinations. But the most important cause for optic neuritis is your multiple sclerosis, unless otherwise proved. Or even that it can go in for a primary optic atrophy sometimes. Primary optic atrophy, the most important cause is multiple sclerosis. Again, you tell, don't change the answer. But you can tell there are so many causes, but the most important cause is multiple sclerosis. That's the most important, because treatable neuritis can go in for primary optic atrophy. We have got any optic neuritis can go in for primary unless the papillitis is there. Then only you can have post-papillidemic optic atrophy, post-papillitic optic atrophy. It can be infectious or non-infectious. So many things are there. Always remember, once you have got optic neuritis, depends upon the fibers involved. Sometimes the vision may be 6/6. Because when the macular fibers in the center, if they are not, like a vision of 6/6, that's why we call it a 6/6 neuritis. But still, I told you, peripheral neuritis may be there. That's the reason. So that's why 6/6 neuritis was one of the things we call it as. Most important major symptoms were visual loss, then pain in and around eyes, and color vision problems. Imagine now, the visual acuity may be reduced, but the color vision will be affected more, as in the case of optic neuritis. The comparative visual acuity, the visual color vision loss is more, whereas in macular lesions, correspondingly, vision may be affected, color vision may not be affected much. There's a difference, classical difference between optic neuritis and macular problems and all. Pain around the eyes and all, the reason is when you have a movements, elevation and adduction. We have got the tendons of the middle rectus and the superior rectus. They have got connection to the dura mater of the optic nerve at the apex of the orbit. That's why when these muscles contract, elevate or adduct, a patient can experience pain. This is what is called as Whitnall hypothesis. Any PG is that they can note down Whitnall hypothesis, Whitnall. Then we can sometimes, multiple sclerosis patient is there. Uthoff sign is there. Uthoff sign is what? When you increase the body temperature of the patient, or when you exercise, the patient does some exercise, there will be something, chemical mediators or chemical substances are liberated, the demyelinating areas. Demyelinating areas, they can get liberated. Further delay what the transmission of impulse. That's the reason the visual acuity can come down. One more thing is there, the demyelinating areas are there, the plaques are there. These plaques become edematous when you increase the body temperature. That's why they can compress the optic nerve further, the problem can increase. That's the reason for visual acuity reduction after exercise and all in a case of multiple sclerosis, that too in a case of optic neuritis. And never forget, usually optic neuritis was unilateral. But in children, sometimes they can be bilateral. So bilateral optic neuritis is very common, and usually in children, usually because of infections. Usually because of infections, classically, I think you might have heard about inferior petrosal sinus. That sinus area, the problem is there. The inflammation may be there. Inflammation may be there, which can affect your optic nerve and all these things. That's the reason for this. We can have RAPD is there. Understand now? Quantify. You can quantify the RAPD. How much of RAPD is there in the patient? How to quantify? See, just put a filter in front of the normal eye. In front of the normal eye, you put a filter. Decrease amount of light entering that eye. So that means the RAPD can be neutralized. That means you create in such a way the amount of reduction in the abnormal eye, optic neuritis eye, is equivalent to amount of light entering that normal eye. That means by putting a filter, you are decreasing the amount of light. That means equalize. That means your relative apparent pupil defect can be reduced or can be neutralized. That's called quantifications. Fundus examination, you're supposed to know papillitis, you can have inflammatory edema is there, optic nerve, you can have, most important point here is what? You can have cells in the vitreous. Whereas in a papilledema, all cells may not be in the vitreous. Visual fields, I told you now, we got central scotoma is there. Central scotoma is a common question for them. When you have a central scotoma, how do you fix? How do you proceed with the field charting? They will ask you. Because the patient cannot fix the center. How can you proceed further? Always there are so many ways. But in Humphrey perimeter, what we are using nowadays, just know that central scotoma is there, you cannot fix the central light. Then how to proceed? Your answer is, there is a large diamond is there, sir. Ask the patient to fix it's in the diamond. The fellow should not come out. So because he cannot fix, the same thing can be asked in germ screen and all. Suppose you're asked, germ screen, you can have some two ribbons, do less. They ask the patient to fix somewhere the ribbon may cross. You may not appreciate the crossing area, but yes, you should not come out of that area. Suppose the ribbon is not there, you can tell him, you can put a ring on the screen, ask him to be within the ring, he should not come out. Suppose the ring is also not there, the patient himself, he can use his thumb. The thumb, because proprioceptive impulse is there, he can fix. That's why ask the patient to put his own thumb, then you can find out the fields. That's the way you have to draw, or we have to chart out the fields in the case of optic neuritis patients, because he's having a central scotomas. Other demyelinating problems, of course, we have got Devix, all these things, Schilder's and all. Devix is what now they got Neuro optica. Here, what's the most important? Bilateral visual loss. That's the most important point. Bilateral visual loss, visual acuity reduction may be there in these patients. Para-infections means what? After viral infections, the patient can develop optic neuritis. Infections, classically, never forget cat scratch, syphilis, Lyme disease, cryptococcal. Now here, as a PG, we'll ask you, what is cat scratch is caused by, we'll ask you in exams. Just remember them with Bartonella henselae. At least know some of the names of the bacteria. Non-infectious sarcoidosis. Here, what you now, most important point in optic neuritis in sarcoidosis, lumpy and bumpy disc. That's the most important name you're supposed that's a name you're supposed to know. Lumpy and bumpy disc, the classical appearance of sarcoidosis. Neuroretinitis, here one important question will ask you. Never forget, demyelinating problems like multiple sclerosis will never develop neuroretinitis because retina has got no myelin sheath. That's why multiple sclerosis, usually normal circumstances, will not affect your retina. Never forget this. This is the most important point, classical exam question. Differential, you can know what, comparative lesions, sinusitis, all these things supposed to do the investigations. But here when I tell you, if you ask the exam, the sinus, which is responsible for the most common sinus, which can produce optic neuritis, if you ask the exams, your answer is sphenoidal sinusitis. Other sinuses are there. Sphenoidal sinus is notorious to produce optic neuritis because it's a very thin bone is there in the optic canal area. This, of course, yes, these are some of the investigations. AIOS can mimic. They can also have a problem like this. Diagnosis, you have to rule of CT scan and MRI and all. Etiology means what? You have to do syphilis means you have to do some syphilis investigations for syphilis. Suppose I want to do tuberculosis, I have to do some investigation for tuberculosis. Like that, you can know, that's all. You know some etiology is there. You investigate for that particular etiology, that's all. Suppose you have got multiple sclerosis. Here is one classical thing called HLA-BT101. This HLA-BT101, that fellow, if he is having optic neuritis, you can 100% sure that fellow will, in future, he will develop multiple sclerosis. That's the most important thing you're supposed to know, because that's a predictor. Okay. Other studies in optic neuritis, the treatment part and all, we got optic neuritis treatment trial, CHAMPS studies, that control high risk. These are all treatment part. CHAMPS means control high risk AVNX. AVNX means interferon beta 1A. Whereas ETOMS, early treatment of multiple sclerosis study. There are so many studies involved in this optic neuritis treatment. These are some of the things that's mainly for postgraduate students. Now never forget, because the patient is going to come to you first, because he's having visual loss. He's come to you as an ophthalmologist. Now your idea is what? You must know this patient in future may develop multiple sclerosis. That means you have to control multiples because he can have more severe effects. That's a problem. Our idea is to find out the patient, early find out, early after a referral to neurologist is the must. Thank you.
Sir, thank you so much for your rapid fire on optic neuritis, sir.
Now I call upon Dr. Chandrasekhar for his talk on papillary edema.
Respected Professor VRV sir, my co-instructors and dear friends, nice to see so many of you. Sometimes halls are, we have more speakers than the people attending. We are happy to see you. My next 10-minute talk would be on papilledema, overview of papilledema. So basically, if you look at papilledema, the disc is something where it is you look into the eye, you can see the vessels and the nerve directly, and only place where you can see directly like this. Why it's called papilla, I do not know. How many of you know? Because those days they used to see the disc in the dead people. In the dead person, the disc will get swollen. That is why it was called papilla. So it's a misnomer by itself. The other terms used are strong papillae and choked disc. And Parson coined the word papilledema, first reported in a brain tumor, and then it was Patton and Holmes who said the main thing is when there is a raised ICT with disc edema, it's called papilledema. So disc edema with raised ICT is the most important thing. Now there are a number of causes like raised intracranial irritation because of blockage of ventricular system and so on and so forth. But the most important theory is that of Sequencing eye ray, where axonal transport mechanism is affected. That is the accepted theory for papilledema formation. So etiology for disc edema, it could be ocular causes. It's only disc edema. Acute hypertonia, acute hypotony, CRVO, they are not called papilledema. Orbital causes, space occupying lesions in the apex of the orbit are causes for disc edema. Now all papilledemas are disc edemas, but all disc edemas are not papilledemas. So this is raised ICP, anything, any space occupying inflammation or anything intracranially will cause raised intracranial tension. Cranial oxycephaly like conditions, CSF changes like Landry-Guillain-Barré, pseudotumor cerebri, or now what we call it as benign idiopathic hypertension. Then you have the tumors of the spinal cord. So IIH and all these things are very important today. Now the most important is, apart from that, systemic disease like hypertension is very important. This papilledema is not only vision threatening in later stages, it can be life threatening in grade 4 hypertensive retinopathy, some of the very violent tumors also. So we can get conditions like this where one side you get a papilledema and the other side you don't have. So ICT lower on one side, then it could be one side. Excess of atrophic glial tissue on one side, it could be unilateral. Then you have the normal disc on one side, that's what I said, atrophic side. The most important what we all talk about is the Foster Kennedy syndrome, ipsilateral optic atrophy and contralateral papilledema. This is, apart from that, the triad is there will be an anosmia because of olfactory frontal groove or frontal lobe meningiomas. So this is the triad of Foster Kennedy. Symptoms are basically not much of symptoms like in optic neuritis. It can be symptomless or transient blurrings could be there. Then peripheral field will get constricted later on, not the central field. But sometimes the disc, blind spot enlargement we can elicit. Central centrocec, all this will depend on which part of the nerve is involved in your papilledema. So basically the raised eyes, it could be due to the cause, primarily headache, nausea, vomiting and all those things. If there is a sixth nerve palsy, diplopia, altered level of consciousness and so forth. So the Cushing triad for ICT is increased systolic blood pressure, bradycardia and abnormal respiratory pattern, which is a clue to raised ICT. Pupil could be dilated, nerve palsy will be the sixth nerve commonly. There are two gradings, Prison's grading, and there is a halo. Now this is the newer one where there is a halo, partially halo, vessels obscured totally or not. So this is clinically, we classify them into so many types. The original Hoyt and Beeston is easier, where you say early papilledema when blurring on one side, established papilledema, which is the acute papilledema. Then we talk about the champagne-cork appearance or the vintage papilledema, which is chronic, and then the atrophic papilledema. So this is early, you can see blurring on one side, and this is mild hyperemia is there. Supranasally it will start, and mild venous engorgement. This is the early papilledema. If we can diagnose at that point, that will be. Today we have this ultrasound B scan. We can catch ICT, raised ICT and papilledemas, disc edemas with the typical crescent sign. Spontaneous venous pulsations will be absent. So this is a sign where it is absent. So established papilledema, total disc will be hyperemic, blood margin and cup will be totally filled. The retinal veins will be more engorged and peripapillary hemorrhages could be there. Chronic papilledema is called champagne-cork, mushrooms like that into the vitreous cavity. It is not that hyperemic, it will be less. Cup is absent, hemorrhages and exudates will become less. This will be the chronic one. Atrophic is, there will be blurred margin and atrophy will set in. We need to differentiate. This is also secondary optic atrophy. It could be differentiated from post-neuritic optic atrophy. So this is one atrophic papilledema. So these are the things we need to know. And reverse tapering of vessels will be there in post-neuritic optic atrophy. During papilledema, you can get the choroidal folds and all. Benign, this is the benign ICT, which is bilateral papilledema, raised ICT. The ventricular system should be normal or small in the neuroimaging, normal CSF study. These are the basic aspects of idiopathic intracranial hypertension. So investigations are, we want to know whether there is any functional defect, because papilledema will not affect immediately. So we need to follow them visual acuity with visual fields. Fluorescent angiography, how it will help us, if there is papillitis, it will be a patchy hyperfluorescence, whereas in papilledema, it will be a diffuse hyperfluorescence. And optic neuritis will get central and centrocecal scrotum. There are 4 types of optic neuritis. Central, axial will produce central and centrocecal. Periaxial around similarly, whereas peripheral, when the bile vessel, the peripheral optic neuritis occurs, we'll get constriction of fields. So transverse, complete optic nerve. Then you have the FFA neuroradiological signs. They are very, very confirmative for any intracranial lesions. And CSF study like in Freund syndrome or something, we need to look at the study, protein count and so on. Very important is the fields will only be affected later. It could be enlargement of blind spot, central or centrocecal scotomas when the optic nerve is definitely becoming atrophic, and peripheral constriction of fields. So this is something like a patient with bilateral disc edema. So she was referred postpartum. You can see disc edema bilaterally. So basically she's a young girl postpartum. So we saw the disc edema in both eyes. Then CT scan did not reveal much. But then the MRI of this girl showed multiple intracranial cystic cysts. Not only that, all over the body, some thousands of cysts. Unfortunately, they could not save her. This is the diffuse hyperfluorescence of fundus fluorescent angiography. Now, as far as management is concerned, we need to treat the primary cause only. So the primary cause is removal of the space occupying lesion if possible. When it is not touchable, then we go in for ventriculo-auricular or ventriculo-peritoneal or so many shunts. So when both of this is not being possible and we see that the function of the optic nerve is getting affected, we need to do a local nerve sheath decompression. It could be an anterior approach, it could be supra-lid, trans-lid. So many approaches are there. So optic nerve sheath decompression will help to avoid further worsening of the optic nerve function. So this is how it is made. On the table we can see vascular changes following the optic nerve decompression, which is called the DV-Cus technique. This is one of the trans-lid approaches. So many approaches are there. Ultimately, we need to know whether it is a pseudopapilledema or pseudopapillitis or whatever, differentiate from all the congenital conditions. But it is important for us to identify papilledema, sometimes to save the life of the patient. So most important for PGs, there are about so many 13, 14 differences between the papillitis and the papilledema. You say normally there are exceptions. Unilateral in papillitis, papilledema, onset is acute. This is insidious, could be insidious. Vision affected early in neuritis and later and so on and so forth. So vitreous haze, anterior vitreous haze could be there, and other things like it is all relative. Though we say more than 3 diopters and less than 3, it is a relative finding. So fields could be, I told you, peripheral constriction in papillitis. It could be centrocecal depending on the nerve. Most importantly, central centrocecal scotomas and blind spot enlargement. Fluorescent, I said, patchy hyperfluorescence versus diffuse hyperfluorescence. One more test which you can write in your exam. Don't tell the examiner, they may not know. If you do a AC tap, in papillitis you will likely to get cells, and papilledema you won't get. So this is a short overview of papilledema. Thank you so much for the opportunity. Thank you, sir.
Thank you, Chandra, very much. Fantastic lecture. But for if PGs are there, I will tell you one thing. We have got, when you're asked in exams, papilledema, what's the most important investigation you're supposed to do? Your answer is taking blood pressure, that's all. Afterwards, you can tell whatever you feel like. Understand now? And one more, and the enlargement of blind spot is because of what? They will ask you. Separation of layers of retina from the disc margin and peripapillary retinal detachment. There are two things. Separation of layers of retina from disc margin, and there is peripapillary retinal detachment is there. These are the two reasons for your enlargement of blind spot. Now I request Dr. Karthik.
I'd just like to make a comment on what sir said. When Karthik is getting ready, I've seen 3 patients, including one of my own employee. We saw frequent change of glasses, near vision, because of the mild edema. Then we diagnosed papilledema, grade 4 papilledema. When say grade 3, grade 4 hypertensive retinopathy, that means systemic is involved. And they had a nephropathy, and later on went in for neuropathy, and we lost the patient within 4 months. So that's what I said. It is life-saving when we diagnose. Sometimes ophthalmologists diagnose papilledema. Now invite my colleague Karthik to talk about optic atrophy. At this point, I'll take leave as we have a symposium on cluster end off and reactions. Professor VRV sir will run the show. Thank you so much, all of you.
Thank you, Chandra. Thank you.
Good afternoon, everyone. I thank Dr. Chandrasekhar sir, AIOS APAO Scientific Committee for giving me this opportunity. My presentation will be on optic atrophy. Optic atrophy is not a disease in itself, but a clinical sign characterized by pallor of optic disc caused by irreversible damage to the retinal ganglion cells and axons. It is the end stage of a disease process affecting the retinogeniculate portion of the visual pathway. There will be change in color and structure of the optic disc associated with variable degrees of visual dysfunction. There are 1.2 million axons of ganglion cells of retina, which are heavily myelinated by oligodendrocytes, and they remain unmyelinated until traversing lamina cribrosa. Axons are optically similar to a fiber optic cable, and the incident light undergoes total internal reflection in the axonal fibers, and the light reflected back by the capillaries on the disc surface gives a yellow-pink color to the normal healthy disc. And the degenerated axons don't possess this optical property, giving a pale appearance of the atrophic disc. Ophthalmoscopically, we classify optic atrophy into primary, secondary, consecutive, and glaucomatous optic atrophy. In primary optic atrophy, there will be orderly degeneration of the optic nerve fibers, which are replaced by columns of glial cells, no previous swelling of the optic disc, no alteration in the architecture of the optic nerve head, and the disc is chalky white in color, sharply demarcated, and the retinal vessels are normal. Lamina cribrosa is well seen. The common causes are pituitary tumor, tumor of the optic nerve, traumatic optic neuropathy, and multiple sclerosis. Secondary optic atrophy occurs as a consequence of long-standing swelling of the optic disc. There is marked degeneration of the optic nerve fibers and excessive proliferation of glial tissue, and the architecture is lost, resulting in an indistinct margin. There will be dirty gray color of the optic disc with the margins poorly defined. Lamina cribrosa is obscured by proliferating fibroglial tissue, and there will be peripapillary sclerosed vessels. The most common causes are papillitis, anterior ischemic optic neuropathy, and papilledema. In consecutive optic atrophy, there will be waxy pallor of the disc with a normal margin and physiological cup with marked attenuation of arteries. The causes are retinitis pigmentosa, status post central retinal artery occlusion, or other retinal and choroidal pathologies. In glaucomatous optic atrophy, there will be marked cup with vertical enlargement, laminar dot sign, backward bowing of lamina cribrosa, bayoneting and nasal shifting of retinal vessels with peripapillary halo and atrophy. This slide shows the etiological classification of optic atrophy. They can also present as temporal pallor of optic disc. The temporal side of the disc is normally paler than the nasal side because there are more fibers nasally. So a real temporal pallor is pallor of the disc associated with the signs of optic nerve dysfunction. The causes can be chiasmal compression, toxic or nutritional optic neuropathy, and cone dystrophy. There are other non-pathological causes for temporal pallor which has to be differentiated from, like axial myopia, myelinated nerve fibers, optic disc pit, tilted disc, optic nerve hypoplasia, disc coloboma, and optic disc drusen. So the aim of clinical evaluation in a case of optic atrophy is to determine the possible cause of the disc pallor, whether there is an ongoing process which is likely to progress as in compressive etiology, or is it a result of a previous one-time insult like ischemic, traumatic or toxic etiology which is going to be static, and to determine the visual prognosis. In all these cases, the prognosis will be guarded, and here our main aim will be to preserve the functional vision whatever is remaining, and also to protect the fellow eye and to decide on the further intervention. Detailed history is very important in cases of optic atrophy, including defective vision, whether it is sudden or gradual, painful or painless, progressive or static, any history of trauma, obstructive sleep apnea, and medication history including diabetes, hypertension, hyperlipidemia, cardiac issues, stroke, and mainly anti-tuberculosis treatment including ethambutol, history of smoking, alcohol or tobacco intake. And a review of records is very important in all cases of optic atrophy, because we are seeing the patient at some time later where the pathology has occurred previously. The examination should include best corrected visual acuity, color vision, visual fields, contrast sensitivity, and pupils will show RAPD in unilateral and asymmetric cases, and fundus examination. Here I am presenting a case of 49-year-old female who came with complaints of defective vision in both eyes for past 2 years, which was gradually progressive, no history of trauma, and the best corrected visual acuity was 6.9 in right eye and 6.6 parts in left eye, with ill-sustained pupil reaction and impaired color vision in both eyes. This was her fundus picture, which showed both eyes primary optic atrophy, and her visual fields showed bitemporal hemianopia. An MRI was done, which showed a pituitary macroadenoma. And 3 months post excision of the tumor, this was her visual field, which showed resolution of field effect in the left eye, but still there is persistent defect in the right eye. So in cases of chiasmal compression, we need not get classical bitemporal hemianopia in all cases. Sometimes it can be asymmetric. They can have poor vision in one eye and the other eye showing temporal hemianopia, or depressed field in one eye and supratemporal hemianopia in the other eye, junctional scotoma. So if the affected eye is having very less vision, always HFA of the fellow eye has to be done, which will give us the clue. So all cases of primary optic atrophy warrants neuroimaging to rule out chiasmal compression or space occupying lesion. And it can occur post retrobulbar neuritis also. So history and review of records is very important in such cases, and we have to see whether they are adequately evaluated, including NMO and MOG antibody, to prevent further recurrence. Another patient, 56-year-old male who was diabetic, hypertensive and hyperlipidemic with complaints of defective vision in right eye for past 1 year, which was sudden in onset and painless, and defective vision in left eye, which was for 4 months, which is again sudden onset and painless, had a best corrected visual acuity of 5/60 in right eye and 6/12 in left eye, and he was not able to read the color plates in right eye and the left eye was normal. He had ill-sustained pupil reaction in both eyes. This was his fundus picture, which showed secondary optic atrophy in right eye and a sectoral pallor in the left eye. And Humphrey visual field analysis of the left eye showed inferior altitudinal field effect. So we came to the conclusion of diagnosis of secondary optic atrophy, secondary to non-arthritic anterior ischemic optic neuropathy. So as this was covered by Dr. Saravanan sir, NAION will present with altitudinal field defect, and the other eye will have a disc at risk, and blood investigations has to be titrated to look into the systemic parameters, and cardiac evaluation and Doppler study has to be done to rule out thromboembolic causes, and CRP and serum homocysteine has to be done in these patients. And long-standing papilledema can result in secondary optic atrophy. So they will be bilateral. They will be having history of headache, vomiting, transient obscuration of vision, and tinnitus. Once a secondary optic atrophy has set in, this disc will not show any edema again when there is increased intracranial pressure. A dead nerve cannot swell again. So in such cases, B scan to look for crescent sign will be more helpful. And toxic optic neuropathy, after the change in the regimen of anti-tuberculosis treatment, we are frequently seeing ethambutol optic neuropathy, and the mean duration for the toxicity to develop is 8 weeks, and they present with bitemporal field effects. So timely cessation and replacement of ethambutol will save the vision. If there is no improvement or worsening of the vision even after stopping ethambutol, then neuroimaging has to be done to rule out other causes, and also we have to consider INH toxicity. Linezolid is another drug which is used as a second line treatment in tuberculosis treatment, that is also noted to have optic neuropathy. And in all cases of tobacco alcohol induced optic neuropathy, neuroimaging once has to be done to rule out central causes before labeling it as tobacco alcohol amblyopia. A nutritional optic neuropathy, usually these patients present to us with a headache and the vision will be good, and they can present as a diffuse pallor or a temporal pallor of the optic disc. For all these patients, along with anemia treatment, Humphrey visual field analysis has to be done once not to miss any coexistent central cause. Traumatic optic neuropathy can present as primary optic atrophy. It takes 1 month for the atrophy to set in from the time of trauma. review of records and history is very important in all these patients. If the history is not accounting for traumatic optic neuropathy, neuroimaging is needed. And we have to see whether adequate neuroimaging has been done, indirect ophthalmoscopy to look into the retinal peripheries, and Humphrey visual field analysis of the fellow eye has to be done, and these patients has to be given protective glasses. Lastly, compressive optic neuropathy can present as a gradual painless loss of vision with a relative afferent pupillary defect. They can have any field defect and transient obscuration of vision on eye movements. It can be caused by chiasmal compression due to pituitary macroadenoma, craniopharyngioma or suprasellar meningioma, or optic nerve tumors like glioma, meningioma, and thyroid eye disease or orbital tumors. So to conclude, optic atrophy is not a disease in itself, but a clinical sign. Thank you.
Thank you, Karthik. Really nice explanation of all these optic atrophies. Now, I request Amrita. Before that, I will tell you, they will ask in exams for postgraduates, because it's only instruction course. They will ask you to define optic atrophy. I think many of us may not be knowing how to define. Your answer should be, it's an ophthalmoscopic finding. That is, status of optic disc when the axons have got degenerated. That's all you're supposed to tell in the exams. Now, one more exam question is how do you differentiate a post-papilledemic optic atrophy from post-papillitic optic atrophy? One is inflammation, one is non-inflammatory. Your answer should be post-papillitic, usually unilateral. Post-papilledemic, usually bilateral. And post-papillitic, because of the inflammation, the arteries may be narrowed near the disc. That is called reverse taper sign. These are some of the questions I want to tell. And one more thing, he told about RAPD, afferent pupillary defect. Never forget, in optic tract lesions, suppose I'm having a right optic tract lesion is there, left eye will show RAPD. Always contralateral eye will show RAPD, because our nasal retina is very important for the activity of pupil. Never forget this point. I request Dr. Amrita now.
Thank you, sir. Sir is my ophthalmology guru. He's the best teacher I've ever seen. Thank you, sir. So, last but not the least, my topic is on yet another important section of neuro-ophthalmology, that is the pediatric neuro-ophthalmology. So I'll be talking about pediatric optic nerve head disorders. So why do we need to know the importance of catching these children young? Are because many of these pediatric optic nerve head disorders are quite misleading, and sometimes there can be a delay in diagnosis. We have to catch them young because they are in the neuroplastic age group. So if you can correct their refractive errors, and if you can correct the superimposed amblyopia in this age group, at least the visual prognosis is better in these kids. And also, these optic nerve head disorders gives a clue towards the underlying systemic condition. So careful disc evaluation in a kid gives a lot of clue for the underlying conditions. So let's know what is a normal disc. So normal disc in a kid usually is pink colored, more of vertically oval than rounded as you see in adults. Average cup disc ratio is around 0.3. Of course, it is variable. It is slightly elevated from the surface, and the RNFL layer is quite thicker in kids as compared to that of adults. So one more clinching point here I would like to say is, whenever you're examining a child, you're holding the eye tight and you're trying to force the child, the child is crying, sometimes you get to see a pale disc. So that is because of the pressure on the eyeball, or because of a crying child. So you should always be careful while seeing the disc of a child. So these are some of the topics which I'll be discussing today. So for understanding point, I have divided it into congenital and acquired optic nerve head disorders. Let's first discuss some of the normal variants of a disc. So suppose you see this picture in a patient. Sometimes even patients are referred with these conditions thinking it might be a cotton wool spot or a vascular occlusion, because a large myelinated nerve fiber is sometimes confusing and misleading. So the clinching points here is it will start at the disc. Usually it has a very feathery margin at the end. So it can be present at the disc, or it can even be present elsewhere also, away from the disc. So it will usually appear as a white, elevated or yellowish lesion So it is normal in 0.5 to 1% of normal population it is seen. Sometimes it can be associated with myopia and amblyopias. So it is asymptomatic, you don't have to really do anything, but always make a note of any myelinated nerve fiber, the location and the size, because the importance lies when there is a disappearance of the pre-existing myelinated nerve fiber, which can happen in any of the demyelinating disorders. So presence is not of much importance. If it disappears, then that is more important. So optic nerve head drusen, it is a great mimicker of optic disc edema. Many a times kids gets referred with this blurred disc margin, suspecting disc edema. They would have undergone a lot of investigations before coming. So these optic nerve head drusens are nothing but a refractive calcified nodules which are seen on the surface of the optic nerve head. So superficial drusens are quite easy to identify, but a buried drusen, which is quite common in kids because they are still underlying, as the age advances, the drusen can come up. So buried drusen is sometimes confusing. It is important to differentiate between a true disc edema and a pseudo disc edema. So some of the clinical signs where you can actually differentiate between a true disc edema and a pseudo disc edema are, so the top picture shows a pseudo disc edema. Usually it will be an elevated lesion, blurred disc margin, and you can see that the capillaries, if you follow a capillary over the surface, usually it will be continuous, and there won't be any much of vascular tortuosity as you see in a true disc edema. As compared to that of the lower picture, you can see the blurring of disc margin is there, vascular tortuosity is more. You can see some of the flame-shaped hemorrhages, and you can see disappearance of capillaries. They get buried under the edema in a true disc edema. These are some clinching points clinically. So the more diagnostic are these three investigations to differentiate between a true and a pseudo disc edema. If it is a superficial drusen, you can pick it up with fundus autofluorescence, where it gives a bright hyperfluorescent foci over the disc. The easy way of diagnosis is a B scan. B scan can show a highly echogenic foci over the disc. The best test you can do to identify a true and a pseudo disc edema is OCT, because OCT gives a clear-cut diagnosis. Both superficial as well as buried drusen can be picked up with this. So it gives a hyperreflective core with the surrounding hyperreflective borders. With the advent of enhanced depth OCTs, even a buried drusen can be picked up easily. Moving on to congenital optic nerve head anomalies. So this is a fundus picture of a child. You can see on the right side it is a normal looking disc. In the left side you can see a smaller disc, and you can see a peripapillary pigmentation, and the vasculature, if you see compared to the disc, they look little larger and more tortuous. So what is this condition? So this is a case of optic nerve head hypoplasia. So optic nerve hypoplasia is quite often missed. The incidence is more than what we actually diagnose. And whenever you see a optic nerve hypoplasia, always ask the history. There will be history of mother having a use of a teratogenic drug, alcohol abuse, or tobacco usage during pregnancy, or there can be a gestational diabetes. And if you see optic nerve head hypoplasia, there can be associated conditions such as microphthalmos, aniridia, coloboma, nystagmus, and strabismus. So always look into the systemic associations. So they can have a lot of neurological anomalies. It can be absence of septum pellucidum, anencephaly, cerebral malformations, and dilated fourth ventricles. Always you should do for a endocrine workup, because they are associated with pituitary hormone abnormalities. So you should always look for de Morsius syndrome. De Morsius syndrome is a triad of optic nerve hypoplasia, absence of septum pellucidum with pituitary hormone abnormalities. So whenever you see a child with optic nerve hypoplasia, do these workups. Do an MRI to find out the underlying malformations in the brain, and do an endocrine workup, which includes all the pituitary hormones, that is the fasting morning cortisol, glucose level, TSH, and prolactin levels. So you can do, some of the optic nerve hypoplasia are associated with genetic background, so you can go for a genetic analysis. The common gene associated is HESX1. Younger children, you can do a sexual hormone assay, because you can give a prediction that they can have a sexual developmental delay by doing these hormonal assays. So here is an excavated disc, large excavated disc, radial vessels, peripapillary hypopigmentation with a central glial tuft. This is called as morning glory disc anomaly because it resembles a morning glory flower. So this is a sporadic condition. The visual acuity usually is relatively poor in most of the cases in this morning glory disc. Whenever you see a morning glory disc, look for these ocular associations. They can have optic nerve calcification, glial tuft, microphthalmos, and sometimes they can end up with retinal detachment. Systemically, all the morning glories will have midline anomalies. So you can see that they have a widely shaped, widely spaced orbits, hypertelorism, they can have cleft-lipped, cleft palate. Even in brain, there are midline anomalies. It can be encephaloceles, corpus callosum agenesis, and Moya-Moya disease. Moya-Moya disease is a condition where you see narrowing of the cerebral arteries. So whenever you find a child with a morning glory disc, do an MRA to find out this Moya disease. So of course, optic nerve head coloboma is also quite common. Whenever it is associated with a choroidal coloboma, it is quite easy to identify. Isolated optic nerve head colobomas are quite confusing. Sometimes it can be mistaken for a glaucomatous optic atrophy or a glaucomatous nerve damage. So it is always important to identify these conditions. So any optic nerve head coloboma can have associated other colobomas, that is iris coloboma, there can be choroidal colobomas. You can see a notch in the lens once you dilate the child. They can have thin vascular membranes which can lead to retinal detachment and also macular holes. These are the ocular associations. Systemically, there are a lot of syndromes associated with coloboma. If you see a child with hearing abnormalities, genitourinary malformations, then think of CHARS syndrome. They can also have cardiac anomalies. And one more syndromic association is renal coloboma syndrome, where then can have renal failure. And Aicardi syndrome is child can have, again, a lot of cranial malformations. They can present with infantile spasm, developmental delay. So whenever you see a child with optic nerve head coloboma, you should refer them to a pediatrician, a neurologist, do a renal workup, and also MRI and echocardiogram. These are all important. These are other common anomalies which we find, that is the optic disc pit, which is usually asymptomatic, but they can present with serous macular detachments at later age, third or fourth decade of life. So it's important to make a note of it when you identify it in a kid. Tilted disc is when the optic nerve enters the optic nerve head in an oblique manner. It gives a tilted disc. Tilted disc can sometimes be misleading. It can be confused for glaucomatous disc damage or myopic disc. Moving on to acquired optic nerve head anomalies, I think most of the topics have been covered. I'll be just talking about the pediatric perspective of all these conditions. So pediatric optic neuritis, as sir already told, how is it different from adults? Adults, as you said, it is like more of a unilateral condition, more in females. Here, in children, it is more of a bilateral presentation. Usually, it's a profound loss of vision. Vision will be either hand movements or counting fingers, PL plus. It will be like a profound loss of vision. So pain on eye movements is quite typical in adults, but it is very rare in children. They don't present with this typical symptom. Disc edema is the common presentation. We don't see much of retrobulbar neuritis. It is more of a disc edema. Usually they respond very well for steroids. So common cause here is post-viral. So post-viral infection and post-vaccination, you see a lot of optic neuritis happening. So with advent of a lot of investigations as we are doing, more of immunological workup, we see a lot of cases presenting with neuromyelitis optica and NMO-related spectrum disorders. So whenever you see an optic nerve, long segment of optic nerve involvement with chiasmal involvement, and the visual, the response to steroid is poor, that is when you think of NMO. So you have to do an extensive workup for that. You have to refer the child to a neurologist because they might need immunosuppression. And the other one is the MOG, again relatively rare than NMO, ADM, and multiple sclerosis. These are the other common causes which you have to think in a pediatric optic neuritis. The next, coming to the management of optic neuritis, do a thorough ophthalmic evaluation, color vision. In an uncooperative child, you can do a VEP and OCTs and visual fields in a cooperative child. Never to miss with MRI with contrast, do a brain, orbit, as well as a spine MRI, because there might be demyelination even in the spine, especially in NMO cases. Antibody assay has to be done for NMO and MOG, and of course, a neurologist workup is required for all these cases. Disc edema in child, as I already told, always differentiate between a true disc edema and a pseudo disc edema. So common cause for disc edema in a child is IH, hydrocephalus, space occupying lesions, infections, inflammations, and some of the medications. So never hesitate to do an MRI even with the slightest doubt of disc edema. So optic atrophy, as already discussed, it's a sequelae of previous optic nerve insult. So in children, the common causes with survival of more premature children, more of perinatal ischemic insult, that seems to be the most common cause for optic atrophy. Not the complete optic atrophy, at least the segmental optic atrophies are common in these cases. Of course, hereditary causes are also common. So we have to identify whether it's a one-time insult or a progressive condition. So the management starts with thorough history, maternal history, birth history, and then of course if there's a family history, do a gene panel workup for optic atrophy, heritable disorders. Most of the children with optic atrophy can have an associated cortical visual impairment. So addressing this condition is very important in a child. So you have to enroll the child in vision therapy, and also you have to help them with their education with low vision aids and also assisted education. So to conclude, taking a thorough detailed history is important. A thorough systemic workup is very important. So diagnose them early and treat them early, and it requires a multidisciplinary approach. Thank you.
Thank you, Amrita. Very nice lecture. For completion's sake, I will tell you only 3 minutes left for us. Sometimes we'll ask in for examinations, what is poloretina? Poloretina, P-O-L-O. That's nothing but a myelinated nerve fiber in the fundus. It's called poloretina. Polo means chicken. You know, chicken has got normally myelin sheath inside the fundus, whereas human is something is rare. Whereas chicken has got normally myelin sheath. One more animal which can have normally myelin sheath is rabbit. These are all some of the viva questions. Never forget, we'll ask you in exams. Then what is chicken eyes? We'll ask you. What is chicken eyes? Chicken eyes means chicken is night blind. Please remember, that means a person who is having vitamin D deficiency, night blindness, called chicken eyes. These are some of the funny questions in examinations for postgraduates. Then FFA in MNF, myelinated nerve fiber, will ask you. Of course, you will tell what block fluorescence, or you will tell. But late stages, what happens now? The fluorescein can come to my vitreous. The fluorescein in the vitreous can absorb the blue light, and then they come in green. This green goes back and hitting on the myelin sheath, reflected. That means the myelin sheath appears green for us, but it's not emitting light. It's only pseudo-fluorescence. Myelinated nerve fiber can produce pseudo-fluorescence because it reflects the green light. That is the fluorescence from the vitreous. This is what the common question we'll ask you. Thank you very much for your patience hearing. Nice thing, we had a very good time. Thank you very much.